Got it. And then, you're welcome to ask me questions if you want to unmute yourself or if you want to put it in the chat box, whatever works. I mean, if you put it in the chat box, I might not be able to see that while I'm presenting, but I'll sort of get back to it towards the end of this talk. But like really open to making it as interactive as you guys want. So, it's derm for IM physicians, which is, again, it's a very broad topic. So I'm going to make sure that it's relevant to you guys. Nothing from like a disclosure that's relevant to this discussion. The threefold sort of objectives are to see common, to sort of know the main, skin diseases that you might see in an outpatient IM setting. I mean, again, there's warts, there's acne, there's fungal skin infections. So I was like, we cannot possibly talk about that this is like not enough time. So I wanted to focus on eczema and psoriasis because they're really the most common skin conditions that we as dermatologists see, and certainly you guys as primary care IM will see that in the outpatient setting as the first point of contact. And then just sort of being able to distinguish between the two is important. I am not taking any deep dives in treating them. I'll sort of briefly just mention, from a primary care perspective, things that can be used to treat them. We'll segue into inpatient dermatology. And I think I'm just sort of focused on two conditions. One is from like a room derm perspective, and the other one is more from like a derm ER, ID sort of perspective. I'm talking about PSA as well. So after I finish talking about psoriasis, I'll talk about PSA up there. Right. Okay, so I know it's a very scary sort of slide talking about the pathogenesis of AD, but the reason why I have it is there's a barrier defect obviously that allows allergens from the outside to sort of enter and incite an inflammatory response. But the reason is there's a predominant role of Th2, and Th2 is our atopic disease immune pathway, and that's also implicated in asthma, seasonal allergies. And you guys will see asthma, seasonal allergies, and AD certainly. And there is Dupixent or dupilumab, which blocks. Hold on, let me get my. Oh no, not closed captioning. Sorry, laser pointer. Yep. Right, hold on. Right, so there is a molecule that blocks IL-4/13, and there's another one. Certainly, you might see patients in your practice that are on these products. So eventually, what happens is there's this inflammatory cascade that gets activated, eventually resulting in, over a period of time, the thickness that you see in chronic eczema. Eczema can look differently on different skin types. Classic cubital area, you'll see excoriations, you'll see the sort of pink patches or plaques. If it's thickened, you can have it on the upper neck. Basically, any part of the body that you have skin, you can have eczema. Certainly, cubital fossa and popliteal fossa, sort of like the areas where you have eczema. So again, popliteal fossa. In sort of darker skin types, the red or the pink might not be that noticeable. And that's where the whole hyperpigmentation comes into play, and the lichenification, which is thickening, comes into play. So this is just to sort of, I have pictures of diverse skin types just to sort of give you an idea that eczema on a darker skin tone looks very different than on a lighter skin tone. Most pictures are my own patients, and then the ones that are not, which are from derm textbooks, will point out that they are from derm textbooks. So lichenification is the thickening that happens when you're chronically scratching something. And then these are just examples of lichenification. So where you see there are these thickened plaques. Plaques are things that are not flush with the skin, but they are sort of lifted up or thicker. And then you have this exaggeration of skin lines. That is a characteristic feature of lichenification. So eczema, if it's chronic and it's been picked on, will become thickened and will look like this. So it wouldn't have that red oozy appearance of acute eczema, but it'll be more thickened and hyperpigmented even. In skin of color or diverse skin types, eczema can have a follicular sort of pattern, and follicular means you see these little tiny sort of circles, and they could be around hair follicles, and this is what eczema on a darker skin color will look like. So again, if you see something like this, do think of eczema, because it does not look like it does in the first few images that I showed you. Okay, again, just another image to drive home the point that it almost looks like these little tiny papules. They can be excoriated. They could be a little hyperpigmented compared to the rest of the skin. And this is just from chronic picking. And then again, prurigo nodularis can be seen with eczema, or it can be seen without eczema. And that's basically just these thickened hyperkeratotic papules. They could be the size of a pencil eraser. Certainly prurigo nodularis can be seen in other underlying medical conditions such as chronic kidney disease, chronic liver disease. So that's just something to, be mindful or like think of. And certainly, you guys do see patients with chronic liver dysfunction and chronic kidney disease. And we do have a molecule that is approved for prurigo, got approved a few months ago. So, there is treatment that can be used to alleviate these patients' symptoms. Again, lichenification with the exaggeration of the skin lines. And that's seen in chronic AD. Again, skin of color, there's a lot of hyperpigmentation, lichenification. In lighter skin types, you sort of see more pink, red excoriations and less in terms of the hyperpigmentation. So this is just to sort of draw parallel comparisons between a darker skin type and a lighter skin type. Eyelid eczema is a very common place to have atopic dermatitis or eczema. And then when I say eczema, this is kind of like the catch-all term for like an itchy rash on the skin. Eczema has different subtypes. So if the patient just has it on their eyelid, it's eyelid dermatitis. This is on the shin, and this is something that's commonly seen in the drier months. When it's cold outside, there's dry heat indoors, can be seen in any age groups, but generally it's elderly patients where they have this cracking on the shins. And this is, it's a fancy term called eczema crackle. I will make a joke right now, and I know I'm being recorded. In dermatology, we kind of like giving fancy names. We just want to make it appear very hard. So that's that. It's called eczema crackle, and this is sort of like the dry riverbed sign. So for those of you who've probably seen images of dry riverbed, you see that sort of cracking, and that's the dry riverbed sign in eczema crackle. So that's a type of eczema as well. Then you have dyshydrotic eczema, and this is a picture of a hand where you see these sort of vesicles. This is not herpes, this sort of vesicles and extremely itchy. So that's dyshydrotic eczema. And that's commonly seen in hands and feet. The reason why I have this is very often we, get consulted on the inpatient service for this, for a patient who has, psoriasis and has like recurrent infections. The reason why I have this here is that of the two main skin conditions, atopic dermatitis, which we just discussed, and then I'll segue to psoriasis in subsequent slides, there are differences. Of course, clinically they look different, and sometimes they don't look different, so it's harder to diagnose other than a biopsy telling us what it is. But atopic dermatitis, or patients that have eczematous dermatitis, tend to have a lot of skin infections, notably with staph. And the reason behind that is something called antimicrobial peptides in patients that have eczema. And these are images of acute eczema biopsies, and this is a chronic eczema biopsy, and that's why it's thickened like that. This is a stain for human beta defensin, which is a type of antimicrobial peptide. In eczema skin, it's markedly reduced. And that is the reason why patients that have eczema tend to have a lot of recurrent staph infections or just skin infections in general. To give you a comparison, this is normal skin. You can see a little bit of red or pink, and that's the staining for human beta defensin. The analogy is psoriasis. So this is another common skin condition that we see in the derm space, and certainly you will see as well. Psoriasis tends to have high antimicrobial peptides, which means they don't have skin infections. So you will not see a psoriasis patient, no matter how ugly their lesions look, with the flaking, the redness, the scaling, they will not have a skin infection because of psoriasis, because they have elevated antimicrobial peptides. So that's another way that, clinically, we as dermatologists can differentiate between eczema and psoriasis, because sometimes they can look similar to the naked eye. Now, this is another type of skin infection that is very unique to patients that have eczema, and this is known as eczema herpeticum. You can see these punched out ulcers. And this is, of course, this is a child that has really bad atopic dermatitis or eczema. So eczema patients are at an increased risk of herpes infection. And, sometimes oral acyclovir or Valtrex is enough. If it's sort of more generalized, then they need to be admitted for IV antivirals. Okay. Will not belabor treatment because, from a treatment perspective, so when I did internal medicine, I kind of didn't know, nobody taught us anything about topical steroids and whatnot. So I always tell my, my med students and my IM family medicine residents that come to my clinic that all you need to do is you have to remember 3 main sort of types of steroids. So hydrocortisone 2.5% is a mild steroid. Triamcinolone 0.1% is a moderate potency steroid. And clobetasol 0.05% is a high potency steroid. And you can sort of use this for any skin inflammatory issues such as eczema or psoriasis. Mild, good for face, sensitive areas, like genital area, axilla because there's thinner skin. Moderate, sort of good for sort of trunk, arms, legs. Clobetasol more for hands and feet, or if lesions are very thickened, because it's the most potent topical steroid. So just remember one from each category so you don't have to remember a dozen different names. So obviously steroids are first line for eczema, but then we also have steroid sparing agents. And this is where it might get a little tricky for you guys, because depending on the kind of insurance a patient has, they might need prior authorization. But again, if you're being adventurous or you want to treat your patient just because they're there or they can't see a dermatologist for like 3 months, then you can sort of move to a steroid sparing agent. And Elidel or Protopic are the 2 that have been around historically, safe to use for as long, because there's no sort of side effect of systemic absorption either. It's not going to thin the skin. And the only caveat that I tell my patients is that it might sting a little when you first start using it. And that's nothing to be, concerned about. So again, Elidel or tacrolimus, which is Protopic. Okay. These are sort of next level. These will definitely need a prior authorization, but I sort of have them there because, they can be considered if a patient is using a lot of steroids or has sort of can't get off of steroids or has, failed steroids, then you can use Eucrisa, which is a topical phosphodiesterase 4 inhibitor, so PDE4. There is an oral molecule called apremilast or Tesla, which is approved for psoriasis. So this is just kind of like a sister molecule in a topical version. And then we have ruxolitinib, which is a topical JAK inhibitor. Okay, we do have systemic options for eczema, and I sort of have names of them here, not with this idea that I want you to prescribe, but certainly you're welcome to prescribe if you feel comfortable. But these are sort of next step for moderate to severe atopic dermatitis or eczematous dermatitis. You have Dupixent, which blocks the 413 that I showed you in my first slide. Then you have Adbury, which just blocks IL-13. And, both of them, they're not immune suppressants. There's really no package insert, which talks about monitoring for anything. So very safe to use. This has been approved, dupilumab has been approved for children as little as infants as little as 6 months. So that's, it's pretty, it's a great molecule for eczema. In the lower part of this picture, you have oral JAK inhibitors. So remember, I showed a topical JAK inhibitor that's used to treat eczema topically. So we have oral JAK inhibitors. Very likely that you might see patients in your practice that are on this. Unfortunately, JAK inhibitors are strong immune suppressants. There is a black box warning of increased cardiac disease or MACE events and malignancy when it comes to JAK inhibitor use systemically. And the data for that came from tofacitinib, which is a different JAK molecule, which is not approved for atopic dermatitis, because once it was approved for rheumatoid arthritis, the FDA asked Pfizer, the company that makes tofacitinib, to do a phase 4, open label sort of safety study looking at whether there was an increased signal for cardiac disease and malignancy, which that open label long-term extension sort of showed that there was. So that's why there's a package insert with that black box warning. That's for all JAK inhibitors, including the topical one that I showed you. So even Opzelura has that package insert for cardiac disease and malignancy. So that wraps up eczema. I can sort of take a brief pause right now to ask if anybody has any questions about eczema. If not, I can move to psoriasis, which is the second sort of I mean, it's the commonest skin condition that we see. I should have put psoriasis first and then eczema. So that was my mistake. So that's the second most, or the commonest skin condition that I see as a dermatologist, is certainly you as a primary care practitioner will see as well. Any questions about eczema? If not, we can move to psoriasis. Okay, so psoriasis is a little different. Anytime you see an erythematous scaly plaque is that it's thicker from the normal skin around it, and it has a well-defined margin. So if you see I'm trailing the margin of that psoriasis on that patient's elbow, so that is psoriasis. Psoriasis is seen around the, so it's in the elbow area or it's in the knee, as opposed to eczema, which was in the cubital fossa and the popliteal fossa. So sometimes just how this, the skin lesion looks, as well as the geographic distribution, clues us in whether it's psoriasis or eczema. So again, another example of psoriasis on this patient. I know you're like, oh my God, this looks just the same as the eczema chart you showed me, but it's a little different because in psoriasis, it's Th17 that plays a predominant role. So you have IL-17, anti-TNF, and IL-23 that are increased in patients that have psoriasis. And there are biologics that block 17, block anti-TNF, that block TNF, and block 23 that are approved for psoriasis, and also approved for psoriatic arthritis, and have pretty robust skin response. Was there anything else in the slide? No, there isn't. Yeah. Now, in skin of color, psoriasis looks different. As you saw from the previous sort of section, eczema also looks different in skin of color. So in skin of color, there's less of the red that you see. You still see lesions that have well-circumscribed margins. The flaking or the scaling may not be there. So like for this patient, there isn't much in terms of the heaped up scales that we see in psoriasis. For the the image in the middle, there is heaped up scaling, and sometimes clinically it's hard to diagnose. So I do a biopsy just to confirm my clinical suspicion. So like I said, in skin of color or darker skin types, there is less conspicuous erythema. Lesions can be hyperpigmented, which means they are dark, or they can even be purplish. So here there's like a little purplish hue to this lesion. Right. And then certainly patients tend to have a lot of post-inflammatory hypopigmentation or hyperpigmentation, which means that they just have, as the lesions heal, they either heal with a darker patch or a lighter patch. And that's commonly seen in darker skin types. And then, it can look like anything, there's lichen planus or cutaneous lupus that it can look like. So unless of course it's obviously clear to me, I do sometimes do a biopsy just to reconfirm my clinical suspicion and rule other things out. Now, the reason why psoriasis is important is it is associated with metabolic syndrome. Way back when, in 2006, Dr. Joel Gelfand, who's at UPenn, basically looked at the adjusted relative risk of MI in patients that have psoriasis. And what he came up with is that the risk of MI is greatest in patients that have severe psoriasis, and it remains even after controlling for traditional cardiovascular risk factors. And that's where the whole psoriasis with metabolic syndrome came into being. And then, since then, there's been enough data that says that, anti-TNF use for psoriasis decreases the risk of, cardiac events, because, anti-TNFs have been around for upwards of 20 years. So there's definitely a lot of data when it comes to that. And then the theory is that if you decrease systemic inflammation by clearing psoriasis, you sort of decrease the cardiovascular burden from sort of systemic inflammation that is there, because increased systemic inflammation, increased pro-inflammatory cytokines in the blood do increase the risk of atherosclerosis. So that's that. For those of you who are looking at that screen and you're like, does the relative risk of MI decrease as you get older? Because that's, that doesn't make any sense. Oh, that's because these people were dead. So they didn't have a lot of old people because they died from MI whenever they did. So that's the reason why this graph looks like that. But, the risk of cardiac disease is certainly higher in older age people as well. But this is psoriasis, controlling for traditional cardiovascular risk factors. Young people with severe psoriasis do have an increased risk of MI. Okay. Again, well-defined erythematous scaly plaques. Sometimes they can be hidden in the scalp. So this is an important thing to note because, here and there, I have patients that see me for a diagnosis of psoriatic arthritis, and they have nothing on their skin, and I'm like looking at their scalp, and I'm like, you have psoriasis in your scalp. And I'll talk about the risk factors of PSA in just a few slides. So looking in the scalp, inside the ears, it's helpful because you can have psoriasis that's kind of hiding there. The third place where you should look as well is genital area. I mean, I'll be honest, nobody in, I did IM, and I used to have a clinic. I don't think I saw a single genital lesion for anybody in the 3 years that I was doing IM in my continuity clinic. So yeah, that's that, because, patients don't want to talk about that. So you can certainly, if you wish, you can ask, and you'll see some psoriasis there. Then psoriasis also comes in different flavors. This is an example of guttate psoriasis. And guttate means it almost looks like these little tiny dewdrops of psoriasis scattered all over. The left image shows something known as a Kebner phenomenon, which is basically wherever you have trauma, patients develop psoriasis. So you see this distribution of linear psoriasis lesions. That's because this patient scratched himself or herself in his abdomen, and that's where he or she developed psoriasis lesions in a linear arrangement. So that's Kebner phenomenon. And that's also one way I sort of clinically can distinguish psoriasis from eczema. Right. Then, yeah, this is a terrible patient. Sorry for that. This is from like my derm textbook. So this is erythrodermic psoriasis, and these are the patients who will get admitted, to a hospital inpatient service. So erythrodermic psoriasis is a severe subset of psoriasis where you have erythema upwards of 80% of body surface area. And back in the day, we would give these patients cyclosporin. Certainly with the newer biologics. So IL-17 blockers are very fast acting. So sometimes I have given patients who are admitted to the hospital IL-17 blockers. I know it's not formulary, so we have to sort of give them samples. But yeah, cyclosporin or IL-17 blockers are sort of fastest acting for erythrodermic psoriasis, and that's one of the ways of treating it. Then you have, psoriasis, which can look like this, where you have these sort of pustules in the periphery, or, you have these erythematous patches or plaques, and then you have these sterile pustules, and this is like pustular psoriasis. It can be anywhere on the body, or if it's just localized to hands and feet, that's a form of pustular psoriasis that's just localized to hands and feet. So that's also a subtype of psoriasis. This is a little less common of all the different types of psoriasis that I just discussed. Of course, hold on, let me go back. So this is like traditional psoriasis. This is mostly the kind of psoriasis you'll see in your practice. So this is psoriasis vulgaris, again, a guttate psoriasis, erythrodermic, pustular psoriasis. And then sometimes you can just have involvement of palms and soles with this sort of hyperkeratotic thickened patches and plaques. And if you see how I know this is psoriasis is if you look at the wrist of this patient, you'll see sort of lesions of psoriasis. But this is palmoplantar psoriasis, which is also a pretty, it's less responsive to the treatments that we use for psoriasis elsewhere. Okay. Again, same thing, hydrocortisone, triamcinolone clobetasol, mild, moderate, severe. Elidel and protopic are overlapping with eczema treatment as steroid-sparing agents. But then we have two newer molecules which are more specific for psoriasis. This is a second generation PDE4 inhibitor that's in a topical formulation. Its oral version is approved for COPD. So that's it's roflumilast, which is an oral molecule. I forget the brand for it. It starts with a D, but that's approved for COPD, and that's been around for, I think, about 5 years. In topical version, it got approved a few months ago for psoriasis. Again, this is for the adventurous ones amongst you, because it definitely needs a prior authorization. Okay. Now, that sort of looks at psoriasis on the skin. Now, I do think nail psoriasis is important for you guys because of nail fungus. And nail psoriasis can look very different. And, it's sort of, as you can see in the clinical, the slide in front of you, mostly what we see in nail psoriasis is pitting, which is this indentation on the nails. Then you can have leukonychia, which is just these white dots. Then you can have what is known as red macules in the lunula. So you see these red macules. A macule is just like a flat patch less than 1 centimeter in the lunula. The other interesting thing that this patient has is onycholysis. So this is what is onycholysis, and there's another better picture of onycholysis. And the way you can differentiate onycholysis of psoriasis from fungal nail onycholysis is that in psoriasis patients, you'll always see this red halo behind the white onycholyzed nail, which you will not see in nail fungus. So that's one way of differentiating between the two. Splinter hemorrhages are also seen in psoriasis. They're not seen in nail fungus. Hyperkeratosis can be tricky because it can be seen in nail fungus. In this patient, because there's hyperkeratosis and splinter hemorrhages, that's why you favor nail psoriasis over nail fungus. Right? And then not last, but like another thing is the salmon patch or an oil spot, and that's sort of this yellowish, light pink macule that you see in the nail. And then sometimes you can have just frank destruction of the entire nail, and that's crumbling. And tracheonychia is also another sort of manifestation where you can have destruction of the nail matrix, which causes sort of this brittleness to nails and this whitish discoloration. In these two cases, unless of course they have other features of psoriasis, it can be a slightly confusing diagnosis to make. But if it's all 20 nails involved, then I do favor psoriasis over nail fungus. But then again, you can always clip the nail, send it for KOH. If they don't see fungal hyphae, then it sort of reconfirms your clinical suspicion. Now, nail psoriasis, it needs systemics. Topicals do not work. Often I have patients that come in to see me on a topical for nail disease, and I'm like, no, it's not going to work. So nothing works for nail, like topicals do not work for nail psoriasis. Okay, next slide. Okay, now psoriasis and HIV is also sort of, there's a robust association because sometimes psoriasis might be the first and only sign of HIV infection because of, the immune dysregulation that happens. As a IM resident, I definitely remember seeing HIV patients admitted with like extensive psoriasis, and hopefully with the advent of, if patients don't know that they have HIV, they can be admitted for like extensive erythrodermic psoriasis, and that's when you find out that they have HIV. Or if they have HIV and they sort of go on and off their meds, that can also flare psoriasis in some such patients. And also important, as I mentioned, if you have a patient that has sort of explosive onset of erythroderma or pustular psoriasis, always think of HIV and test them for HIV in such a condition. Now, then there is something called reactive arthritis, and that is also something that's important because you could see that either as an outpatient or as an inpatient, and these are patients that have a preceding history of like an infection like dysentery or urethritis with bacteria like Yersinia enterocolitica or Yersinia pseudotuberculosis. And then again, this is a board testable question. I think it could come in from like an ID part of your boards. Of course, the patients have to be HLA-B27 positive because most of the time reactive arthritis is seen in HLA-B27 positive individuals. And then they develop psoriasiform skin lesions. They have urethritis. If they are female, they can have cervicitis, and then they have peripheral arthritis. A quarter of patients can have conjunctivitis. So it's that triad in reactive arthritis of urethritis and or cervicitis, arthritis, conjunctivitis, and psoriasis on the skin. There is a very distinct skin manifestation, which is called keratoderma blenorachicum, which typically is seen on the palms and soles. This is an example of a feature, of a patient's sole, where you can see sort of this, Eczematous, sort of scaly, sometimes they can be thickened or hyperkeratotic, patches or plaques on their palms and soles. So that can be a board testable question as well. At least I remember when I was doing my IM boards to know about keratoderma blenorachicum. Okay, and now why is psoriasis important? So psoriasis is important because of psoriatic arthritis, because a third of patients with psoriasis will develop psoriatic arthritis. The unfortunate thing is that we have no ways of sort of knowing exactly which patient develops psoriatic arthritis. The lag from the onset of psoriasis to developing psoriatic arthritis can be as long as 7 to 10 years, right? There are certain types of psoriasis, lesions on the skin that have a higher association with psoriatic arthritis. So if you have nail psoriasis, nail or scalp psoriasis, that increases your risk of developing psoriatic arthritis by 3 to 4-fold. Of course, if you have extensive psoriasis, those patients tend to have higher odds of having psoriatic arthritis. But then there are confounding studies that say that a lot of psoriatic arthritis patients don't have a high BSA. And then the reason is that if they have a high body surface area of skin involvement, hopefully they've seen a dermatologist and they've been started on systemic treatments, which are also, concurrently approved for PSA. So it's kind of treating that PSA without actually having a formal diagnosis of PSA. PSA is short for psoriatic arthritis. And then, in terms of what does psoriatic arthritis look like, it can be very diverse. This is a patient of mine, who has involvement of his PIPs, proximal interphalangeal joints. You can see he has a fixed flexion deformity. He couldn't straighten out his fingers. So that's one example. I'm going to get back to the slide in a bit. And then there's another patient of mine who just had knee swelling, unilateral, one knee swelling, and you can see she has psoriasis, plaques, and on her knee and then on her shin. This is another patient of mine who has, again, swelling of her PIP. And, maybe there's a case to be made that there's a little bit of onycholysis here. Another patient, this is same patient, and this is arthritis mutilans. So he had psoriatic arthritis for upwards of 25 years, and this was before biologics were even approved for psoriatic arthritis. So he has that penicillin cup deformity where his distal interphalangeal joint has sort of smushed into his proximal phalanx, and that's arthritis mutilans. We don't see that anymore unless, of course, they've had PSA before the advent of biologics. And the same patient had this mild DIP swelling. And the reason I have these images here is that there is not one phenotype of psoriatic arthritis. It's so heterogeneous that we really have to keep an eye out for it. I'm going to go back this slide. So there are different domains of psoriatic arthritis. 95% of patients have peripheral joint involvement, so hands and feet. Psoriasis certainly precedes the development of psoriatic arthritis in 85% patients. 60% patients have nail psoriasis. 50% patients have dactylitis, and dactylitis is what is called sausage digit, which means either a couple of fingers, a couple of toes are completely swollen. They can be, if it's acute, they can be painful. If it's more chronic, then there's just some swelling with some discomfort. Enthesitis is inflammation where the tendon inserts into the bone. I have an image of enthesitis in subsequent slides. And a third of patients that have psoriatic arthritis can have axial disease, where they talk about pain in their lower back or stiffness when they wake up in the morning or after periods of inexertion. Okay. So this is an example of enthesitis, and this is the Achilles tendon. This patient has obvious swelling on the right Achilles tendon compared to the left. This is enthesitis, which is seen with psoriatic arthritis. Oh, I have an image of dactylitis. So that's the sausage digit that I was talking about. The entire second toe is swollen, it's red, it's painful. And that is dactylitis, and that's a domain of psoriatic arthritis. So if you have a patient with psoriasis who you see and they have like a swelling of their finger or toe like that, absolutely think of psoriatic arthritis because that is what they have. And then another thing, you can see that this person's nails are like all destroyed. So that's from nail psoriasis. Okay. Now this is from my room book. As I mentioned, it does come in different phenotypes. You have DIP involvement that can be predominant, similar to that picture I showed you. Then you can have mutilating arthritis, which we don't really see anymore. That's another picture that I showed you. Then you can have patients that have symmetrical polyarthritis, and they complain of, swelling and pain in their MCPs, PIPs, and it almost looks like rheumatoid arthritis. But if they have skin psoriasis, and it's psoriatic arthritis and not RA. Then you can have axial disease, which is the spondylitis. Again, a third of patients have that when they have PSA. And then the fifth is that they have asymmetrical oligoarticular, which means that they have maybe a knee on the right leg and an elbow on the left side, or an MCP on the right hand. So, different joints in different parts of the body. Okay. In terms of distinguishing, again, I'm not going to talk a lot about it, but the two things that I'll point out is that enthesitis and dactylitis are unique to psoriatic arthritis, and they're not seen with rheumatoid arthritis. So that's just one thing to be mindful of. And certainly nail psoriasis, if you have a patient that has skin psoriasis, has nail changes, then their arthritic symptoms are from PSA and not from RA. Again, there are always exceptions to that rule, but for the most part, it'll be psoriatic arthritis. Okay, so that is the second skin thing that we will see in an outpatient setting. I'm going to segue to something that the GI folks amongst us might like. If anybody has any questions, I can take a break right now, or else I can keep going. Okay. Right, so we will segue to skin manifestations that can be seen with IBD. And this is a very comprehensive slide that talks about all the manifestations that can be seen with patients, on the skin with patients that have inflammatory bowel disease. And about 15% of IBD cases do have extraintestinal manifestations. I'm not going to be talking about all of them because we'll stay here forever, but I did want to talk about paradoxical reactions. And paradoxical reactions can be eczema or they can be psoriasis. There's enough published data that talks about paradoxical reactions to biologics that are being used to treat IBD. And these are the very same biologics that are approved to treat that, paradoxical psoriasis reaction that happens. So, it kind of is like, oh, what's going on here? So basically, what paradoxical skin reactions means is that these patients who have inflammatory bowel disease, they develop an immune-mediated and inflammatory skin reaction that develops paradoxically during the treatment of their underlying IBD with biologics that are used to treat the idiopathic counterparts of this drug-induced reaction. So, for instance, Humira or adalimumab is approved for inflammatory bowel disease. It's also approved to treat psoriasis. Here and there, I have patients that get sent to me by my GI colleagues who are on Humira and then they develop psoriasis while on it. So that's what an example of a paradoxical reaction is. The skin is obviously the most frequently involved organ system with the paradoxical reaction, but even then, these are rare reactions to happen. Certainly in an academic institution, there's like a little bit of selection bias, so I see this a lot more frequently than I would say my colleagues who are in private practice. Now, TNF-alpha blocker induced psoriasis is really one of the prototypical paradoxical skin reactions that is seen. There are others as well. We won't go into all of them because, like I said, this is going to take forever. So I'll focus on psoriasis and touch a little bit about eczema. Right. So the prevalence of paradoxical psoriasis is anything from 0.6 to 5.3% of patients that are treated with anti-TNF. Generally, it develops de novo in these patients who do not have a history of that, psoriasis, and they're being treated with a biologic for something else. And sometimes it can get hard. Sometimes it can be a little tricky to diagnose. Is it the drug? Is it just having the disease? Because if you have inflammatory bowel disease, about 16% of patients do have psoriasis. If you have inflammatory bowel disease, about 40% of patients will have concurrent arthropathy, which sort of overlaps with psoriatic arthritis. If you have patients that have just psoriasis, as I mentioned, a third of them will have psoriatic arthritis, but up to 50% can have subclinical gut inflammation that is suggestive of IBD. And the same thing, if you have psoriatic arthritis, 60% of them have subclinical gut inflammation, and about 90% of them have psoriasis. So it's kind of like, sort of a chicken or the egg situation, like which came first. So it can be sometimes hard to treat, hard to diagnose. Is this truly a paradoxical reaction, or is this something that they had and they didn't know that they had psoriasis, or or what? So most of the times, in 60% of cases, they develop in the first year of treatment. You stop the biologic, it clears the skin. And if you retreat with the same or a related biologic, it causes a relapse. So that's one way of finding out. Sometimes you don't have the liberty of doing that. So you just treat them with topicals, or you switch to a different mechanism of action if their skin is very significantly involved. There have been some published data that said that, of course, if you stop the anti-TNF, there's resolution in about 65% cases. If you switch to a different anti-TNF, the odds of resolution are a lot lower. And so this is more of a class effect. So that's a paradoxical psoriasis reaction. So, so like I said, the treatment for that really comes down to how extensive it is. If it's mild and it's like limited in terms of body surface area, I just optimize topicals, especially if their underlying IBD is responsive to what they're on. If it's moderate, severe, and there is clearly on a history taking, there is a association, then I do talk to their GI physician to see if we can switch it to something else, which will cover their IBD as well. So that's that. The second paradoxical reaction that I see is, again, paradoxical eczematous dermatitis. That's less common. So it's about 1% of patients that are treated with anti-TNF. The issue with this is that we don't have much data as opposed to paradoxical psoriasis. I did show you what eczema looks like. So about 1% of patients on an anti-TNF can develop eczematous dermatitis. And I certainly see that in my practice. And then the treatment paradigm sort of stays the same. I have done combination biologics, so they can be on a biologic for their IBD, and then I add dupilumab, which is the biologic for their skin. So I do a lot of combination therapy. Okay, so that takes care of outpatient dermatology for you guys. We'll switch to inpatient. And inpatient is, there's just two main cases because I saw them as an inpatient when I was a derm resident, so I thought this was fascinating. All right, so the first one is, it's more room derm, and you can see this gentleman has these sort of ulcers on his palms, and he has these violaceous patches and macules. Some of them have like a thickening, and that's called hyperkeratosis. Same thing on his feet, sort of these violaceous patches. This patient had dermatomyositis. So there's an entity of, and I'd seen as a derm resident because he was admitted for rapidly progressive ILD. So this is MDA5 dermatomyositis is a subset of DM, a specific phenotype of DM that's associated with this antibody. In Asians, it is associated with rapidly progressive ILD, and that's where this patient could be admitted to the hospital and be seen by you guys. Not seen in Caucasians. The ulcerations is what is very typical of MDA5. So these two images is something that you should probably see in your memory bank somewhere. You see a patient that has this. This is MDA5 DM, always. Right. Won't go into treatment, but then this is good because DM is also associated with a diverse array of antibodies, which again can be both tested for sure, because I remember memorizing them as an IM resident. So MI2 is probably something that you might be tested on. That's the classic DM skin lesions. They have that heliotrope rash, which is the violaceous discoloration around the eyelids. They have Gottron sign, V sign, Scholl sign, ragged cuticles. Other antibodies which are less common is NXP2, and this has an increased risk of malignancy, so this can be tested as well. Jo1 is our anti-synthetase syndrome, and that's the one that has that mechanics hand and the triad of arthritis, myositis, and ILD. This can be testable as well. MDA5 is that thing that I showed you. It's always amyopathic. Amyopathic means that they have no muscle weakness whatsoever. Rapidly progressive, fatal interstitial lung disease. The last antibodies are TIF1 antibody, and this is important because this has the highest overall risk of malignancy. Because DM does have an association with malignancy. So any patient that has DM needs to get screened for malignancy annually. And the TIF1 antibody is the one that has the highest overall risk of malignancy. There are two clinical phenotypes or images, findings of anti-TIF1, which are unique to this subset. The first is this red on white discoloration that you can see on this person's forehead. And then the second thing is that ovoid palatal patch. So you'll see sort of this pink, red, patch with sort of areas of atrophy in between, and this is on the hard palate. So this is the one that's associated with TIF1 antibody DM. Now this is a patient of mine. You have this heliotrope rash. Obviously you have this erythema on her face. Can be easily confused with lupus. The way to differentiate is that in lupus, the nasolabial folds are spared. In DM, the nasolabial folds are not spared, and that's where the arrow and my laser pointer is. This is our V sign, a sun-exposed area, and you can clearly see the upper part of the neck, the submental area, because it's photoprotective. There's nothing going on here. So this patient had DM. This is what her cuticles look like. They're ragged cuticles. So that's something that's seen in DM, certainly seen in the JO1 phenotype that I talked about, ragged cuticles. And then you have these dilated nail fold capillaries. So this is the same patient in the previous image that had DM. Right? And sometimes you don't need a magnifying glass. You can just it's just obvious even without a magnifying glass when they're this dilated. This was an inpatient. So, DM also comes in different flavors. I forget what she was admitted for. I'd come to see her as a derm resident. Heliotrope rash, one-sided. So it doesn't have to be symmetrical. And then she had the Gautrans, a very subtle Gautrans, sort of this violaceous patch on her knee, so that she had DM. Right. So why DM is important is because of this malignancy association. And I think this is probably where you might get, looped into seeing a DM patient. The incidence of malignancy in DM patients varies from 15 to 30%, but it's higher compared to the risk based on population-based studies. So that's why it behooves us to do malignancy screening for our DM patients. The highest risk is really the first year leading to the diagnosis. So year 0 is when the diagnosis of DM is made. So the highest risk is the year leading to the diagnosis of DM and the first year after. But as you see, the risk is there in year 2, 3. So really in the first 3 to 5 years after the diagnosis of DM is the highest risk. Ovarian cancer or breast cancer is the one that's commonly seen in females, and lung cancer is the one in males is the commonest malignant association with DM. Right? Amyopathic is, the patient of mine that was admitted. And, sometimes that can be a hard diagnosis to make because in our head, DM is always skin and muscle. So we're not thinking of amyopathic DM. And this is important because, a fifth of patients that have DM can be clinically amyopathic, which means they have no muscle enzyme or physical weakness. And these are certainly patients that you might see in your practice, who come to you for like a rash on their skin, and they don't know what it is, right? So this is just something to think of, not for every patient, but just based on the distribution of lesions that I showed you. It's harder to diagnose just because it's amyopathic. Yep, this is it. And then, yep, so that's DM. The second skin condition, that you guys can see admitted in the hospital is generalized pustular psoriasis. It is not a subset of psoriasis because I'll talk about the immune pathogenesis. It's a little different. And what patients have is this, and when they're having a flare of GPP, they have these sudden widespread red patches with, sort of sterile pustules that are at the periphery. They have systemic complaints, like they could be febrile, they can have insensible loss of water, they can even be hypotensive. GPP is hard to diagnose because, they go to the ER, they see their primary, they get, thought of as having a skin infection, they get put on antibiotics, or they see a dermatologist, for the most part, all of us like giving topical steroids as like the first step for everything. It works or not. And then GPP is very rare, so it's not a very common skin condition that is seen. But the reason why I sort of wanted to have it here is because I've certainly seen GPP in Sinai as an inpatient consult, and the few GPP patients that I have, their history is very typical, that they've seen a lot of providers. Nobody really thought of GPP, so it's good to think of GPP in a patient that has these sort of red patches with sterile pustules and has systemic sort of complaints, whether it's fevers, malaise, arthralgias, fatigue, or certainly they're admitted to the hospital or the ER because there is a mortality rate which is about 7%. And the reason why I'm putting this here is that there is a biologic that got approved for GPP a couple of months ago. So it's first time ever approved for GPP. So, an early diagnosis will result in treatment with this, and the response to this molecule is very robust in a week. So the primary endpoint for clinical trials for GPP and this drug was day 7. So that's 1 week. So it's a very fast acting molecule. So that's why I kind of wanted to throw that out here. Now, GPP is different from psoriasis. Firstly, you can just see, there are pustules on an erythematous sort of base. Plaque psoriasis has flaking. Certainly, pustular psoriasis can look like GPP. So that's when you sort of depend on other things. Are the patients sick looking? Do they have high CRP, ESR? Do they have leukocytosis? Do they have neutrophilia? Do they have abnormal LFTs? And then GPP patients also have hypocalcemia. So if I have a patient that has pustules and they have these other systemic complaints, and it's GPP. Certainly, I can do a skin biopsy, which will differentiate GPP from pustular psoriasis. And the reason that's important is because the treatment is completely different. We have an approved molecule now, and treating psoriasis, plaque psoriasis or psoriasis is completely different. Now, GPP is more neutrophil mediated, and there is IL-36 that plays a role. Plaque psoriasis is more IL-23, IL-17. As I mentioned previously, this Spivigo blocks IL-36. So that's how it works for GPP. And yep, that's all. I have nothing else to talk about. I can open this up for any questions you guys might have. I know
Wow.
it's just, yes.
Thank you for that whirlwind tour. And that was amazing.
I know it still doesn't cover all of dermatology. So.
Of course not. And that only means that we'll get to invite you back another day. We have about 7 more minutes, so we invite some questions. It looks like there's a question in the chat.
Right. So the thing with, when a patient is admitted, the fastest acting molecule is a steroid. So that's always something that's given first line. But the idea is, what are you using as a steroid sparing agent? Because they can't be on steroids indefinitely. So that's where, you have an option of Plaquenil, azathioprine, methotrexate, Cellcept, that can be thought of. I do like IVIG. I've had a couple of my DM patients who have like very extensive skin involvement that are admitted to the hospital, and IVIG is really, for me, with extensive skin, becomes kind of first line to treat DM. Yes, Angie.
Angie has her hand up.
Thank you for this amazing talk. I just had a question for the patient that you showed us with guttate psoriasis. Why did he have, or why did they have a kind of like band of clearing?
Oh, so that was the bra. So that was where her bra was.
Oh, okay.
Yeah. So that was, it was just that. Yes, that was the only
Got
reason.
it. Okay. Thank you.
I got a direct message question from Dr. Radin. If you don't mind, Dr. Radin, I'll just read it out loud. Can you say a few words about palmar-plantar dysphagia related to EGFR inhibitors, distinguishing it from other hyperkeratotic disorders of the palms?
Right, so that is a hard question. If a patient is on an EGFR inhibitor, yes, they can have palmar-plantar dysesthesia, or like that burning sensation, or like the redness in their palms and soles. So then it comes kind of down to history of like, did it start after they were put on that EGFR inhibitor? There's certainly a very high association of that as a sort of a side effect to those drugs. It is hard to treat. I know ice packs and sometimes gabapentin, Neurontin has been used. We certainly throw topical steroids at everything, so that can be considered as well. So, I mean, I don't see drug rashes that often, just because everybody in Sinai has their unique niche. But I know I have a colleague. So if you have patients who have that, I can give you the name in the chat box, who sees a lot of onc drug rash. Yep. Any other questions?
I actually have a question regarding treatment of psoriasis in HIV patients. I know we talked about it being, an initial sign of an underlying acute HIV diagnosis. And, I assume that the idea is, if the psoriasis is secondary to the underlying HIV infection, that with the treatment of the HIV, the psoriasis itself will
Will
get.
clear, well, respond, best case scenario, it'll clear, but sometimes that doesn't happen. So I think the treatment really comes down to how extensive it is. If it's limited, then yes, you can use a topical. If it's, and when I say limited, one handprint is 1% body surface area. And, I think about up to 5, maybe even 10% body surface area, people, if they're motivated, can use a topical. So if they are undiagnosed HIV and they've just gotten diagnosed, then it becomes a little tricky putting them on a biologic, because you want that HIV to be treated first. In that case, I do use a lot of phototherapy. That's one thing. Secondly is if they are on HIV, they know that they have HIV and they just kind of got off their meds, then I do say start your HIV meds, and then, you can, I don't necessarily have to wait for, a normal CD4 and undetectable viral load if they have a lot of, more than 10% body surface area and they can't do topicals, they can't do phototherapy. So there's a lot of published data looking at anti-TNFs because, historically anti-TNFs have been around the longest. So there's a lot of data looking at anti-TNFs along with HIV medications or in patients that have HIV, but the newer biologics, the IL-17 blockers, the IL-23 blockers, I would say probably have the same, if not higher safety data with HIV patients. So when I see an HIV patient, if they are on an, on antiretrovirals or they're starting it, I do talk about 17 or 23 blockers. And then I also just tell them, I send a message out to their infection, that HIV doctor, and for the most part, they are fine with that. I've not seen any worsening of HIV with the 17s or the 23 blockers.
Great, thank you so much.
Any other questions?
All right, I think we did it. Thank you so much for joining us. This was amazing.
Thank you so much for having me. Take care, guys.
Thank you, everyone.
Bye-bye.